Elbow. So you can clear, you can do a quick assessment here. Is there any warmth? Any warmth? Work your way down. Otherwise, see if you can straighten it, even though, yes, that's breaking into range of motion. Good, relax. So we're looking for any type of muscle asymmetries with our observation. Great. So we get into our palpation. Other than warmth, we're looking for any atrophy, both visually, and we can palpate for any atrophy. So then if he complains of a certain muscle pain or problem or certain tingling, we can address that area. If he has cardiac issues and he's talking about tingling or dead weight of his arm, maybe we want to check the brachial artery or go into the brachial artery, go into radial ulnar. We could check our pulses, looking for any type of edema, things like that. If he does have edema, is there any pitting of the edema? Does it stay sunken in or does it pop back out quickly? So we're looking at drainage issues. But otherwise, we're just looking to see if we can reproduce his pain. So when it comes to that, two primary areas or main areas people are going to complain of pain for their elbow is between these two spots. So between these two spots, we can look at first bony integrity. So we can look at radial head, and all we do is twist the arm to make sure that the radial head is rotating in place. We can work on lateral epicondyle to make sure that that's a common source of pain. Medial epicondyle, see if that's a source of pain. We can, you can look for just torsion or compression type problems going on between the ulna and the radius. You could do that by just lining them up, just doing a quick little compression. These are just quick screens to do.
Pushing them in towards one another.
Yep.
Just slightly, okay.
We can work on olecranon process. We can work on the olecranon fossa within there as much as we can. Could work our way around the medial side, lateral side. It's important to look at the cubital tunnel, and on the screen it talks about cubital tunnel thickening. Thickening means there's been friction. So friction means something is moving too much, which means it's not getting good stability from the UCL. So frictioning or thickening is important. So that's pretty much bony integrity, then nerve. Now we can go down into the biceps and check out the distal tendon. Gently pull up into me. Good, relax. Make sure the tendon attaches to where it should go. Great. We could check for muscle hypertonicity. That's just if there's a contraction involuntarily. Contraction. Did I miss anything?
Oh, was that it?
Quality of fascia, if you find a reason to. So if he just has an issue, I don't expect a fascial clock issue, but maybe he gets burned, maybe he has a scar from a surgery, that would be a lot more appropriate. But that's usually when we talk about palpation breakout, that's really where we go into a fascial clock assessment. This is supposed to be a quick thing. How does that hurt? Is everything in the right place? Is there a hypertonic muscle? Screen's done. I think I got everything. Sure. Anything else?
Ligaments? Is that more deep? That's more
Ligaments, oh, you don't really grab at the ligaments as much, but you can check like in between the joint to see if in between the joint is a source of pain. In between the joint is a source of pain, that's okay. But you're not going to do any stress testing yet, that's for sure. And that's palpation.
We do use the MS1.
Oh, you could still, if he has a secondary complaint or wrist issues, absolutely. You could do your superficial, you can go into all your events, or all your different bones. If you're looking at muscle attachments, usually if you have a superior muscle problem, like let's say a tendinopathy up here, you're not usually worried about where it attaches to down here as much. But if he complains of, I have pain here and here, yeah, you will go into that.
Column 1.
Column 1, observation and palpation. If I look at just his resting, this is not how I would look at him resting other than his posture. But to me, even though I want to see him rested at his side, I don't see any excessive cubitus valgus. He's not bowing in at all, so I know it's already normal, and it bows out slightly. So that's definitely within 15 degrees, 10 to 15 degrees of valgus, so that's normal. Why do we get a valgus position of our arms again?
Carrying
the hips.
Hips, that's right. That's good. Guys wanna practice that quick? Sounds good.